and we expect you all to finish this course and start helping patients who are in need of palliative care. Thank you so much. We are expecting more participants to join, but as we have reached the time, 5 o'clock is the time to start the session. And I hope you have heard about the ground rules for the session, which will be sent again, circulated through emails. And there will be a WhatsApp group. You can communicate through the group if you have any queries regarding the technical sides or anything regarding the session. So thank you so much. Today we'll be talking about, we'll be giving an introduction to palliative care, what the context and what exactly when we need to consider when we talk about palliative care. So for today's session, we have Dr. Dr. Rajagopal is the chairman of Palliative India, and who have started many activities in the field of palliative care in India. And he has been awarded with the Human Rights Watch Award and Padma Shri in 2018. Sir has been teaching, I think, thousands of people about palliative care. So we are very fortunate to have him today here to introduce palliative care to this group. I understand maybe many of you are familiar with the term, but today we'll be introducing the concepts of palliative care to this group. Welcome you, sir, for today's session. Sir, you're muted. Sir, yeah.
Sri, thank you very much. I see that we have some 45 people. Have the participants already introduced themselves to one another? What's happening today?
No, sir, because these days the groups are really big. We are expecting 78 participants, so it takes a lot of time to introduce individually. But they'll put their name and background in the chat. That's the only introduction we'll be having about this group.
Before I start, I would like you all to write one sentences describing your idea of what palliative care, just only one sentence. What is palliative care? I would like you to write it and share it in the chat box. Can you do me that favor? I am so happy that you are all here. I also understand that you are from various parts of the country. Do we have an also out of country participants this day?
Yes, sir.
Okay. Welcome everybody. Could you please do me that favor of writing down one sentence and putting it on the chat box? What is palliative care? Your idea.
Can you all type your responses in the chat? So there are some responses coming in the chat. Helping people to go through pain, to improve the quality of life. Any other comments? To provide care with respect to pain management, spiritual and other distress. So there are a lot of responses coming in.
Yeah. Let them come. We'll get a few more. Then I'll start.
wide range of responses actually.
Thank you. Thank you for all being so willing to contribute. I also saw a chat message in between asking, I think it was Dr. Deepak who was asking, is it mandatory to have the video on that he is traveling? Dr. Deepak, I know that it may be difficult for you when you are traveling, but I'm glad everybody else has the videos on. I'll explain why we are being fussy about this. It would have been lovely to have everybody in a room, sitting together, looking with eye contact, sharing ideas and interacting easily. Unfortunately, today's situation is that we have to meet only virtually. Even there, the more we are able to see one another, the better. For the next time, at least, Dr. Subbalakshmi, yes, next time, if you will have the light on your face, it will be good. There is some backlight and your face is hardly visible. And the same totally holds true for that Dr. Ajirisha Abdul Naziz. You are just one mass of darkness. Dr. Meherban, the backlight is preventing visibility. I mean, okay, maybe next time it will be nice. I'm glad everybody has the video on. Please have the light on your face and not in the background. My background is that of an anesthetist. I was also an intensive care physician till I started doing palliative care and eventually completely moved over to palliative care alone. Looking back on my life as a clinician, I now keep wishing, I wish I had known this when I saw that patient. I wish I had this idea when we was having, when I faced that problem. Because all of us, we may not talk about it much, live with some sad memories. Sad memories of our own family members who needed care and the appropriate care could not be given. Also about our patients. Patients possibly whom we lost, and possibly somebody who may have a, and especially for me as an anesthetist, somebody ends up with a vegetative existence after a cardiac arrest and resuscitation or other anesthetic accidents like that. I hope, I am glad you are all here because we now can do better. I'm glad you all shared those ideas. I may have more things to add there, and sometimes it may be necessary to dispel some myths. We'll talk about them also. I'm going to share a screen and show you which most of you would know, but you may have forgotten, the WHO's definition of health. Is my screen visible to you?
Yes, sir.
Okay.
Yes, sir, it's visible.
Yes, thank you very much. Got it? Health is not only absence of disease or infirmity, it is physical, social, and mental well-being. I don't know about you, but certainly, I think I know about you also. This is not what we were taught. This is not what we practiced. I was taught to diagnose and treat diseases. Physical well-being. Well, I thought I knew how to treat pain or breathlessness. I thought I knew till I came into palliative care. Social well-being, is that my job? Mental well-being, how on earth do you do that? These are things that struck me only when I entered into medical profession. But this is the definition of health. This definition is 73 years old. It has been there in our community medicine textbooks. How do we practice this? Again, I don't know if you ever wondered what's your duty of care. What is the duty of care of the healthcare provider? In some countries, it is defined by law, not in our country, but our. Will you please keep your microphones muted till you want to really speak out? There's some conversation coming in. The doctor's duty of care is to mitigate suffering. That's also mentioned there. The doctor's duty of health or any healthcare provider's duty is to mitigate suffering primarily. Cure sometimes, relieve often, and to comfort always. That's a 14th century aphorism. And there is no exception to this rule. We do have the duty always to mitigate suffering. And that is what we are going to talk about in this course. The whole course will be on mitigation of health-related suffering. And the relevance in our country is enormous. Every year, more than 26,000 people commit suicide for health-related reasons alone. They form 1/5 of all suicides in our country. Look at that, ladies and gentlemen. More than 26,000 people committing suicide every year for health-related reasons. For every one of them, how many would have attempted and failed? For each one of them who attempts, how many would be living, wishing they had the courage to do it? This kind of suffering is what we are talking about. And many of you, about my question, palliative care, talked about the end of life and terminal care. That is certainly part of palliative care. Palliative care is also for the end of life care. And particularly in that, India is not doing very well at all. This evaluation of the quality of end of life care, they call it quality of death index. This is a ranking of end of life care across the world. Ranking of 80 countries was taken up in 2015. And the results showed India among the worst 15 countries in the world, below Kenya, Zambia, Egypt, Slovakia, etc. So not Slovakia, Slovenia. Why? These are things that we'll have to think about. You can argue that the indexes may be wrong. These are all the Westerners' ideas, etc. But there are some things that we see around us. A Bengali oncologist, Dr. Sankha Mitra, he now lives in Australia. All his salary is spent on palliative care in Northeast. He lives on his wife's salary. And he writes, in India, the poor die in misery, in neglect, like this man. The middle class die in misery of ignorance. The rich die in misery on ventilators. No one gets a pain-free and dignified death. On another occasion, another day, we'll talk in detail about end-of-life care. Of the 45 odd doctors in the group, many would be seeing this in the intensive care unit. Ladies and gentlemen, if I were asked to choose between the two, this man with no pain relief, in absolute misery, obvious poverty, and this man in a first-class ICU, every organ being monitored, if we are talking about it, any day I would choose this. At least where there will be some family members around me. And this is another Indian reality. Catastrophic out-of-pocket health expenditure pushes 55 million Indians below poverty line every year. Did you notice? That's more than 4% of India's population. We define healthcare as physical, social, and mental well-being. If this is what we do, how much of health are we not improving? How much of health are we destroying? Here is a global declaration of some 161 countries or something, of which India was a party. Together, world nations have decided that healthcare should reach people where they are, when they need it. Where they are, when they need it. I see that Dr. Indu is currently in a duty room of a hospital. Dr. Indu, you are working in a hospital. Most of us work in institutions. Do the people who need you get to you? Yes, many people do. But for everyone who gets to you, how many people do you know would be denied of healthcare anywhere? When we reach out to the cities and villages, when our teams go there on home visits, we see how they live and how they die. We have to reach people who are not reached now. And the Astana Declaration also says health for all has to be health with all. With all. They have to be party to this. Unless you give adequate information to people, unless they are part of the care process, unless the community around them is supportive, healthcare will be incomplete. Dr. Swami Pranaga, Dr. Bilal, Dr. Arpita.
Good morning, sir. Good evening, sir.
Good evening. See, we are used to delivering palliative care. When you write a prescription, what percentage of your patients do you think take the medicines as you prescribe? For example, you are prescribing an anti-diabetic, anti-hypertensive, and some cholesterol medication along with 3 other things. Do you think they all are taking them religiously according to your advice? Majority will be taking it or minority will be taking it?
Less than half will be taking, or one-fourth of the one-fourth.
You're right. Only about 1/3 of people actually follow our instructions. If they were our partners, if we and us were writing together, we were deciding on this together, the numbers will improve. And when it improves, you become more successful. And health for all has to be health with all. This is also something that we remember when we try to deliver palliative care. So I initially asked you to write on the chat box what is palliative care. This is not an official WHO definition. The official WHO definition is 19 years old. WHO itself appointed a committee 4 years back to change it. Unfortunately, they could not arrive at consensus. The definition has not been redefined, but this is how a Lancet Commission calls it. I would like you to remember this short sentence, crisp. Prevention and treatment of serious health-related suffering. I paused for a few seconds to allow you to think about it. Prevention and treatment of serious health-related suffering. That means not only pain. In the chat box, some of you mentioned treatment of pain. Well, if you say also include also mental and social pain, maybe. Many of you mentioned terminal illness. Listen, if I am your patient, why should I have to suffer pain or breathlessness till I am almost dying? If I am going through radiation and chemotherapy one after the other, why should my pain not be treated now? Why should I have to wait for 9 months before all the treatment is over to get relief. It's not only for terminally ill. It's not only for the incurable. Any serious health-related suffering. And that might be certainly physical. Pain and other symptoms. Sorry, forgot to put the phone on silent mode. Not only pain and physical symptoms, but also social issues like the poverty. You see, Sridevi must have done thousands of home visits during the past many years. She and people who work with her, or all our home visit teams, now there are 8 teams going out on home visits. We see outpatients in several places. If we know that somebody does not have enough food to eat, we will not just prescribe medicines 3 times a day after food and walk away. We'll make sure that they get food also. Is that doable for you? That may not be doable for you by yourself. Dr. Vignesh or Dr. Delna or Dr. Haifa may not be able to achieve that if you are on your own. But if an institution or an organization takes on the responsibility of treating social suffering also, there are people outside who are willing to help. About 100 food kits go out. Kerala, okay, comparatively compared to other states, poverty is less. Still, we find that among our patients of more than 3,000, about 100 people do not have enough to eat. Every month, they get a kit containing rice and some provisions, dry rations, they call it. But even you don't have to do it. If instead of walking away, suppose you call a local or organization, maybe a Rotary, maybe a Lions on somebody, and say, listen, I have this patient who cannot even have food to eat. Is there anything you can do? Maybe some solutions will occur. Similarly, depression, anxiety, other social issues, other emotional issues, guilt, we recognize them and do what we can. And also spiritual issues. I don't necessarily mean related to God and faith. Also issues like, what's the meaning of my life? I wish I were dead. Nobody wants me, etc. But certainly we'll today talk about just an introduction, not the details. This is a man who had cancer, the lung, which had spread to his bones. He had been in this position for almost 3 weeks when he eventually came to us. Unrelieved cancer pain. The same man after less than 1 hour. We had given small bolus doses of morphine intravenously, 1.5 at a time, every 10 minutes. And with less than 1 hour, that was something like 7 rupees worth of morphine. The man was sitting up after 3 weeks for the first time, enjoying a cup of tea and telling us, God, what all have we been going through. This is what is possible. Well, for everybody, it may not be so dramatic, but to a large extent, these things are doable. What percentage of people with cancer do you think in India get adequate relief from pain? Only 4%. Less than 4%, not even 4%, less than 4%. Dr. Delnas, Dr. Samir, are you surprised? This man had morphine. India is a poppy growing country. We grow poppy. Our factories make opium and morphine. export it to the world. The Westerners get pain relief. Our own people do not get pain relief. More than 96% of people do not get pain relief because you and I have not been taught how to use it, how to assess pain, how exactly it is to be used. 3 generations of doctors have not seen morphine. And okay, maybe you have seen injection, but majority of people not morphine, or not oral morphine. And so this problem is continuing. Dr. CY, which country are you from? Unmute and speak, please.
Sir, can you unmute?
I'm from Malaysia.
Malaysia, okay. Malaysia, Dr. CY, is a lot better than India in this matter. But even there, it's only a minority who get palliative care, not the majority, but certainly
Yes.
a lot better than India. But Ma Ayur Tattva, Ji, which
Yes, sir.
place are you from?
Isha Foundation,
Where are you located?
Coimbatore.
Okay. Yes, I know about your foundation. I have been briefed about it. I'm so glad you are here. Doctor, you, Krishna Priya, Venkatesh, Divana, please think. What do you think is the reason? Is it the cost? It is
No.
one of the cheapest medicines. Why? Why is pain like that untreated? If things were most of the time as simple as this, why not? Sorry. Trying to go back to this picture. You are going to change this. We are all going to change this. This is uncivilized. We have the best of healthcare institutions in the country in terms of technology, imaging, and curative treatment. But we allow suffering to go on. Dr. Surabhi, we'll change it, right?
Yes.
We'll all together change it. This
Yes.
is something that needs to be done. Okay, that was about pain. But I have a question. Now, Dr. Shweta, don't look at the question. You are driving. I don't want you to take any risk. But everybody else, please answer this poll. Sri, will you tell everybody what to do about this? Oh, I hope you do have the poll on. You may not. Okay, don't worry. Here's a question to you. I have given 3 options. Intubate and keep them in ICU. Intubate and ventilate in ICU. Keep him in ICU on mask. Keep him in a private room. If his incurable tumor chokes him and he becomes hypoxic with stridor, he is in the emergency room, what will you do?
Fourth, sir, I'll keep him in a private room and comfort.
Where are you? Or what institution are you from? Which place?
I'm in Assam, sir, in Tezpur, and I'm working with the Ex-Servicemen Veterans Clinic, ECHS organization.
Okay. I'm so glad that you, what's your name, if I may know?
Krishna Priya Banerjee.
Krishna Priya, I'm glad you are able to give that answer. But what do others have to say? You are agreeing to keeping somebody with hypoxia in the private room?
So there are a few responses on B, intubate and ventilate.
Okay. I don't know how many of you are able to have the courage to think about your own death.
I would keep him in ventilate with oxygen. The answer C.
Incurable tumor, doctor.
Yes,
Strider.
sir.
So,
Yes.
okay, I want to force you to think about yourself. I'll tell you about myself. You know that one of every 9 people in India will get cancer. 1 of 9 people in India will get cancer. It's that common. If I have a tumor here, with a glands compressing the trachea or a major bronchus. Incurable. This means you have nothing, you cannot do any curative treatment. You will have to relieve my suffering. Nothing else can you do. Think of me in that position. What would be my priorities? If I am the patient, is my priority is to improve the oxygenation? Stridor means an inspiratory difficulty, not bronchospasm. Inspiratory stridor is what is called usually called stridor. So there is an obstruction to the flow of air. You can give oxygen through an endotracheal tube. It is very unlikely to overcome the obstruction, the endotracheal tube. The obstruction is still there. Now, in addition to my breathlessness, which you may not be able to adequately take care with an oxygen, with an endotracheal tube and with a ventilation, maybe you will be able to get some air in. My hypoxia may improve. And then what? Will I ever get out of that ICU? That means you will be effectively prolonging my dying process from 1 hour to several weeks. Those several weeks are weeks in which I will not be able to see my family except for 5 minutes in the morning and 5 minutes in the evening. And even that time, I will not be able to communicate with them. They will not be able to touch me because I am covered with all cables and wires and there are these bleeps going on all the time. They'll be scared even to touch me. And after suffering the presence of an endotracheal tube, which is a very painful thing to tolerate, eventually I will die. If your duty is to mitigate suffering, prevent and treat suffering, are you performing that role? If in an incurable tumor with hypoxia, you isolate somebody in an intensive care unit and ventilate that person. You know, I am an intensive care doctor. I was not now. I was. I have done this. I know. Sometimes you will be forced to do it by hospital protocols or by pressing families. But what would be best for me? Here is a recommendation, ladies and gentlemen. This is from National Cancer Grid. It's an interesting group. This is a group of almost 200 cancer institutions across the country. The current head is the director of Tata Memorial Center in Mumbai. And National Cancer Grid has given guidelines about management of advanced cancer. And one of them says, do not treat patients with advanced metastatic cancer in ICUs unless there is an acutely reversible event. Dr. Samir, if I am your patient, I don't know what is in store for me. But if I were that patient, I would request you to follow the advice from National Cancer Grid and not isolate me. At least I'll have my son's hand to hold on to or my wife's hand to hold on to, which is precious for me. Yes. What we will do, and this is not only a personal opinion, if you look at management of breathlessness in advanced cancer in the Oxford textbook of palliative medicine, you will find the same thing. Dr. Samir,
Yes,
please
sir.
put me on oxygen. See if my hypoxia improves. It may not. If it
Yes.
doesn't help in 10 minutes, take it away. The mask will only be a botheration. You cannot get the oxygen to my blood. You can only get it up to here or up to here with an endotracheal tube. The obstruction is here. That is futile. If the oxygen does not help, take it away. Be reassuring, but only realistic reassurance. Don't, I mean, if you tell me everything is going to be okay, I know everything is not going to be okay. I know I have advanced cancer. That doesn't reassure me. But if you hold my hand and say, we are going to do everything to make you comfortable, I'll be reassured. If I am reassured, I am less likely to breathe like this. In the presence of an obstruction, the harder you breathe, the more breathless you become.
Yes.
We in advance teach them slow, easy breathing. What medications we will give will be corticosteroids, which will shrink the peritumor edema. Even if 1 millimeter opens up, flow increases 16 times, if you remember your pulmonary physiology.
Yes.
Corticosteroids will take time to act, and morphine becomes the drug of choice. You are worrying about respiratory depression. I'm not suggesting 15 milligrams of morphine. Orally, we would give the person something like 2.5 to 5 milligrams every 6 hours, just enough to reduce the sensation of breathlessness from the beneficial effect of the medicine. And I am sitting here very, very relieved that my dear friend and classmate who died 9 days back with advanced metastatic cancer of the lungs could get a peaceful time and easy breathing with a combination of dexamethasone, just 2 milligrams a day for the last 2 weeks, and morphine, which was also for the pain in her case, but she was taking 5 milligrams 4 times a day, and she died rather peacefully. This is how, in any symptom, we switch from the acute care mode to the palliative care mode. In acute care, your objective is to maintain the oxygenation to save the patient. But here, when the patient life cannot be saved, you switch to palliative intent. And this is what you do. Shall I stop there for just a minute to take any questions?
If anyone has any question, you can either unmute or you can type it in the chat.
Hello, sir.
Hi, who is speaking?
Yeah, my name is Dr. Renjit.
Yes, Dr. Ranjit.
So I don't know whether it's related to this particular topic or not, but there is one. It's regarding one of my patient, terminally ill, a metastatic cancer patient. He is currently bedridden, and I diagnosed the condition and I referred the patient to an oncologist, but he refused to prescribe morphine, and I had to give the patient tramadol and all those gabapentin and all those type of medications. But I just want to ask you that is it possible for an MBBS doctor like me to prescribe morphine, or it is not easily available out there?
Doctor, which state are you in?
I'm from Kerala. Currently, I'm working in the district of Pathanamthitta.
The answer is yes. You cannot prescribe and get it from elsewhere. This is the patient with you right at the moment?
Actually, she's at her home, and
But
I go once a week or twice.
you are able to see the patient. Sridevi, please, we must talk to Dr. Ranjit, right?
Yes, sir.
And discuss how we can get the patient help. Pathanamthitta, there are institutions with morphine availability. In
Okay.
Kerala, it cannot be bought from any medical stores. It will have to be prescribed by recognized medical institutions. Tomorrow itself, please talk with our telehealth team, and together we'll find a solution for that patient. In some states, ladies and gentlemen, it is available in medical stores, some selected pharmacies. For example, in Delhi, just 2 pharmacies sell it. But the prescription will have to be in the proper format. We will talk about it on another day when we discuss opioid availability. But in the meantime, anybody with any patient-related questions like this, please talk to our telehealth program, and together we will find a solution. Sri, will you please put up the number of the telehealth program on the
Yes.
chat box?
Yes, we are doing it, sir. The link.
So,
and the
doctor, that patient possibly needs morphine. We need to understand a little more from you. I cannot do it during the session, but we'll
Okay,
have to find a way.
Okay.
Thank you.
So there are
Thank you, sir.
few questions in the chat
Yes.
also.
Yes.
Is it only for terminally ill patients and bystanders? Before that, there is a question. Sorry. So how does, in palliation, till what extent an invasive intervention can be done?
Doctor, for a question from
Deepak.
Dr. Deepak. Dr. Deepak, you think of me as your patient.
Yes, sir.
You have to think about what will be good for me. If it's incurable cancer, what will be good for my quality of life? What will be good? You have to do that, not something that you will do in the emergency room if there is a traffic accident. So how much invasive things can you do? You saw the National Cancer Grid's advice. You will do anything that will actually add value to my life, quality to my life. If not, it's useless. Just because you have those machines, should I suffer because of them? So that's my answer. You focus on my quality of life and my family. And the other question, it is not only for terminally ill people. Palliative care is for everybody, but at any stage of illness, wait, let me complete. At any stage of illness, you will look for problems that are reversible or not. You saw the National Cancer Grid's recommendation. They would still have you in the ICU if there is an acutely reversible event. For example, you get a severe hyponatremia in end of life, you will not keep him in ICU. But if you get a severe hyponatremia during the course of chemotherapy, that might be reversible. You would treat it aggressively. So depending on my chance of getting better, you will decide how much of interventions should happen. Sorry, you were trying to say something.
Dr. Deepak, were you trying to say something?
Dr. Ashwati Devi, if the patient does not, if I at that time do not improve with oxygen, you give me corticosteroids. You give me small dose of morphine to reduce the sensation of my breathlessness. You allow my family to hold my hand. After you have made me a bit comfortable, you may have to allow me to die. I allowed my classmate, doctor, pediatrician. Eventually, she died with her husband and sons around him. I had prepared them about the event. You will find it difficult, Dr. Ashwati Devi, to accept that. But this is the problem why people have to suffer. You, and I have to accept that death is the inevitable consequence of life. Your duty of care is not to stretch out the dying process and to prolong life at all costs. Your duty is to mitigate suffering, cure when possible, relieve when possible, and comfort always. There is no exception to this rule.
There is a question on the role of morphine in breathlessness.
Yeah.
I think that will be. So you want to answer it now, or
No,
we have?
sorry. I brought up 2 examples of pain and breathlessness. I'm not going to discuss the management of each symptom in detail. There will be discussions in detail. There will be at least 2-3 sessions on pain management. There will be another session where breathlessness is taken in detail. So I will not spend too much of time on it because I have to still talk about some general principles. And if I do not stop in another 10 minutes, Sridevi will get very angry with me. So I will not go into the details, but corticosteroids, ladies and gentlemen, reduce peri-tumor edema. Peri-tumor edema, wherever there is cancer, there is reaction of the body, inflammation around it. And in the lungs, when there is a tumor blocking the airway, even a little reduction in the edema will permit some air to move. The same thing will apply also to several other situations like a nerve compression pain. So morphine reduces sensation of breathlessness in small doses. We will not give enough dose to suppress the respiration. So some of those questions have been answered. As I said, my apologies. I talked about this. Now I am moving on to areas. I'm not moving on to. Sorry, is that the right person? Yeah. Okay. Back to the presentation. I'm not going to discuss the management of breathlessness in detail only because, as Sri very diplomatically pointed out, we will do it on another day. And as we said in the beginning, we realized that suffering can be social and mental or spiritual also. And this is what was called total pain. Do you know who is the founder of palliative care in the world? Anybody?
Dame Sicily.
Dame Cicely Saunders, absolutely.
Yeah.
Who said that? The name, please.
Krishna Priya Banerjee.
Krishna Priya, excellent. Yes, Dame Cicely Saunders, a nurse turned social worker turned doctor from London, the founder of the St. Christopher's Hospice, the first palliative care institution in the world, brought in this concept of total pain, social, physical, spiritual, and emotional. This is how the WHO defines palliative care. 19 years old definition, too long, something that they want to change. But several pieces here will be of interest to you. It is to improve quality of life, not only the patient and their families, not only of incurable diseases, all life-threatening illness, through prevention and relief of suffering, by treating pain and other physical problems, psychological problems, social problems, and spiritual problems. What would be your answer now to this question?
B.
At the onset of serious health-related suffering. Who said that?
Krishna Priya.
Krishna Priya, where are you?
I am in Assam.
Assam, oh, far away. I want to come to you for treatment when I am in that stage. You will be safe for me. But Sri Devi, I am going to shift to Assam.
Sir, I don't know whether people here will be happy or sad.
Okay, you are in some doubt. Okay.
So there are a lot of responses in the chat also about the option D.
Yes, I'm glad you are all thinking in those lines. Think of me from the patient's point of view. My suffering should be treated at the onset of suffering. So in cancer, no one except the oncologist can do it optimally because others will see the patient too late. And I would say request the oncologist, we expect the oncologist to integrate this into their routine practice. As in Western countries, any oncologist would do, you would prescribe the appropriate analgesics or other symptom control. And only if there are difficult symptom controls or difficult pain, you will have to refer to a palliative care unit. So, ladies and gentlemen, the concept of palliative care has moved from a situation where it was no longer responsive to curative treatment. Not anymore. This is 1990. This is wrong. To all life-threatening illness, as was defined by the WHO in 2002, to what I request you all to practice, the recent one, prevention and treatment of serious health-related suffering at any stage of illness, along with treatment of the disease. Of course, end-of-life care becomes a part of it. In the olden days, no longer responsive to curative treatment meant that you would go through all the curative treatment and then only offer palliative care. Here, the both go on. If there is significant suffering, the disease modifying treatment and palliative care go together. And palliative care does not end with the death of the patient. It continues as bereavement support for the family. This is as we practice it. And if that is to happen, I repeat, palliative care units will not be enough. I'm sorry. There is at least one oncologist in the group. Doctor, what's your name?
Sir, you are asking about any oncologists in the group?
There is one. I saw
Yes, I think more than one.
Yeah. Okay, doctors, whether you are an oncologist or a pulmonologist, it doesn't have to be cancer, or a neurologist. The bulk of the care will be by the clinician incorporating palliative care into your practice. As you diagnose the patient, you also start treating the symptoms. And palliative care units need to see only those patients for whom you cannot easily get adequate pain relief. And to all our work, we keep the community in the foundation, the community around the patient. This is what we do. Support from volunteers, charitable organizations. When they all come together, your work becomes very easy. Yeah, sorry, I will not go into the details because time is up. We'll talk more about this when we talk about organizing palliative care. The patients and your institution are far removed now. They do not have even access to it sometimes. And you are bringing in the community. That's a social capital to help us by engaging with charitable organizations and by recruiting volunteers. This is how we will provide palliative care. The time given to me is almost up. We have some time for questions and answers. So, Sri, shall I hand the group back to you for the discussion?
Yes, sir. We have 10 minutes for questions and answers. So either you can unmute and ask your questions, or you can, if you want to share something, that is also possible, or you can type it in the chat.
Ma'am, I want to ask something. Actually,
sir.
I asked the question
I've asked a question from sir in the chat box regarding the extent of palliation in intervention, invasive intervention. I am from West Bengal, Kolkata, ESI Institute of Pain Management, and we had a patient last week suffering from non-Hodgkin's lymphoma, and the patient had been repeatedly been transferred from many units, surgical, oncology, then medical, and everyone was like referring the patient from their department to the others. And finally, our HOD took the patient in our department for a palliative care. But the patient had like gross anasarca. So all
Sorry,
IV
patient
lines
had
had failed.
Anasarka. Yeah. Yes, Deepak.
What we have
Deepak, your voice is breaking.
to be hypoalbuminemia.
Deepak, you are not audible now. Your voice
The
is breaking.
patient was having.
Sri, can you hear him well?
Hello?
Is
No,
it
the
my
voice
problem or?
is, no, the voice is breaking. Dr. Deepak, we couldn't follow the last part of it.
Dr. Deepak, please
The
switch off your
patient was
video.
having.
Yes, please, we can hear now.
You said the patient has Anasarka.
The patient was having albuminemia, but as IV lines were not working.
Sorry, you are not audible now. You can't hear your voice.
We could hear till Anasarka, then it was not clear after that.
I think he's traveling. He's
So,
sitting in a crowded bus or something.
I'm in a train actually, sir. I'm traveling from my institute to my.
Deepak, we are sorry. We'll have to send the question by chat and we'll try to answer it because you are continuously inaudible. Poor signal. Then while Deepak is typing up the question, can we get somebody else's question? Nishant has sent a question. Dr. Nishant asks, if a patient needs intubation and at the same time he won't make it, it's wise to leave patient in palliative care. We should give ICU care. What if there is some chances that he may survive? That is something for you to assess, doctor. That's why I gave that example of advanced incurable cancer. You can say philosophical things that, okay, who are we? We are only human beings. God can do many things. I'm not talking about miracles. If the patient comes to ICU for the first time, you have no choice. You don't know the patient. You have to go into the details. But if you already know that he doesn't have a condition from which there is no reasonable chance of restoration of reasonable quality of life, that would be the phrase. If the patient on assessment by more than one doctor does not have reasonable chances of restoration of reasonable quality of life, then we should avoid infliction of more suffering. You will have to think, you will have to give information to the patient if the patient is still able to hear with compassion and competence. That kind of communication is what you will learn during this course. How will you communicate that bad news? How will you communicate the bad news to the family? Get all to agree and continue to provide palliative care. Never abandon the patient.
So Dr. Deepak has sent his question in the chat.
Deepak, patient had anasarca and hypoalbuminemia. All IV lines had failed, so we planned a Riles tube insertion plus central cannulation. Was it all justified? Doctor, what is the anasarca is widespread edema? What is the reason? Is the hypoalbuminemia associated with some advanced liver disease, which is incurable? Or was it a curable illness? Most likely it was not curable. Is it a condition where you could cause some improvement? Need not cure. Okay, you give the appropriate treatment and patient improves. The central line and the Riles tube, everything may be justifiable if by giving them, you could restore reasonable quality of life. But if the person is having, say, an advanced cirrhosis of the liver, with anasarca and hypoalbuminemia, then you are only adding suffering. In that case, Dr. Deepak, if you know that the patient has an advancing incurable illness, you should avoid that central venous cannulation, of course, with proper explanations to the patient and family. Your effort should be for keeping the person comfortable. Non-Hodgkin's lymphoma. Okay, good. Lymphomas are treatable. This patient with anasarca and hypoalbuminemia, if there seems to be reasonable chance that now by initiating treatment, his life can be saved and he may even get cured. Even if not, he may get some good quality of life for a few years. If that is so, yes. But if he has already gone through the treatment and all treatment have failed, chemotherapy is not working in this case, then your nasogastric tube is adding to the suffering. Your central venous line is adding to the suffering. Shaurya Mehra, Sridevi, when you tell me when I should stop. Dr. Shaurya Mehra asks, in our institute, we plan palliative radiation and also give palliative chemotherapy to advanced stage cancer of head and neck and also cervix. Whether palliative treatment in such severe infections be attempted, shouldn't stick to supportive and pain management only. So we have these choices. One, should we continue cancer treatment? 2, should we continue cancer treatment and palliative care? 3, should we provide only palliative care? Depends. You say it's advanced stage cancer of head and neck. Advanced. How advanced is this? If with the radiation and chemotherapy, the tumor can shrink, the man can breathe and eat again for some time, he may want to live for 6 more months. That's his choice. We should facilitate it. But if it is advanced stage cancer, where your chemotherapy is only and radiation is only going to prolong life of poorer quality, maybe what we will learn during the course is to how to communicate that to the person. Your aim is to reduce suffering for the patient in the short term and long term. But if that man wants to live for some more time, most people want to. And if that is feasible, yes. But if it is advanced incurable cancer, which is not responding well to radiation and chemotherapy, and you don't have to give it, of course not. You're only worsening the suffering. So my choice, if reasonable improvement is likely, go to the middle option, radiation and chemotherapy along with palliative care. Thank you. Thank you everybody for the active participation. It's the time for the case presentation now.
Yes, sir. We can start the presentation and then we can take up questions after the case presentation.
Sridevi, are you facilitating this?
Sir, Dr. Arjun is here to present the case and I'll be here.
Okay. So ladies and gentlemen, it was good to talk to you all. Thank you for the active participation. I leave you to Dr. Sridevi and Dr. Arjun, both my colleagues. Thank you very much.
Thank you. Thank you so much, sir.
Bye-bye.
So as mentioned in the emails and in the beginning, the format for the sessions will be a didactic for the first 45 to 50 minutes, followed by a case presentation where we'll be discussing about a patient story. And there are no questions. It's like an active discussion area where everyone can contribute to the questions and come to a common point of common kind of consensus on how to manage the patient. So for this session, as it is the first session, we'll be doing the presentation from our side. But from next session onwards, everyone have to send their questions or their patient stories before the next session. So we have session on Wednesdays. From today and tomorrow onwards, kindly send in your presentations. It's a mandate for completion of the course. Everyone has to send one patient scenario. You can choose from the list of topics. We have 20 sessions. You can choose from any of the 20 topics and present it to us. So kindly start sending and preparing your presentations. We'll be sending a template. It is very simple, 5 to 6 slides. You just have to mention very clearly the history assessment and your questions so that we can discuss more about that. So today we have Dr. Arjun. Dr. Arjun is working in Palliative, India as a palliative care physician, and he's currently in charge of the telehealth consultation. So we have shared the link to the telehealth consultation in the WhatsApp group. So if you have any queries regarding the patient care, you can just call to that number and let us know. So over to Dr. Arjun for the presentation.
Thank you, Dr. Srivi. Hello all. So we'll start with the case presentation. So we have a 39-year-old male who was diagnosed with a traumatic quadriplegia with stage 4 pressure sore on sacral region and left gluteal region. So he came with complaints of constipation since 2 days, bed sore over sacral region and gluteal region. He was also complaining of moderate pain over the hip region, and there were urinary leakage. So coming to his history, he had a history of fall while carrying a weight, followed by neck pain and weakness of both limbs. And he was later diagnosed with the traumatic quadriplegia in August of 2015. He was admitted and got treatment from one of the government hospital and was discharged afterward. After 6 months, he developed a bed sore over the sacral and gluteal region. Both were of stage 4. And he also complained of history of pain over the hip and wound side for more than 2 weeks. The pain over the hip region, which is scored 5 out of 10, is intermittent burning type of pain bilaterally, and at the wound side, he scored 4 out of 10, which was continuous throbbing type of pain. Due to this, sometimes they keep the wound open. He also has a disturbed sleeping pattern and decreased oral intake. So when we examine him, he was conscious oriented. His temperature was 90 degrees Fahrenheit. Pulse was 82, respiration 20 breaths per minute. BP was 120/70, and systems were within normal limits. So coming more detail to the pressure source, they were warm and tender. X-rays were present. Tunneling was present. They were irregular in shape, and foul smelling was there. So about the investigations which were done, his hemoglobin was 10, total count was 34,000, volume was 80%, lymphocytes 18, eosinophils 2%, and platelets were 1.6 lakhs. His creatinine was 0.9, sodium was 132, and potassium was 4. Coming in detail to his psychosocial aspects, he's a 39-year-old unmarried man who was living with a 65-year-old mother in a rented house. He has one sibling who is married and living separately and not at all caring or helping them. He used to be a manual laborer and was the breadwinner of his family. Now, his mother is a manual laborer and she is taking care of him. The main source of income is from the mother's daily wages, a pension, and some of his friends who are supporting him. They have already taken rupees 1.5 lakhs from a private finance bank for the treatment purpose. He, who was a devout Christian, now unable to go to church, which makes him very sad. He communicates through a cell phone. He often says to his mother, like, I don't think I can walk, so please don't spend money over my treatment. So main concerns were the pressure sore, the pain, and financial problems. Now, to summarize, we have a 39-year-old man with traumatic quadriplegia with bed sore present over the sacral and left gluteal region, both stage 4 with pain over the hip region. Now, discussion points. Do we need to provide palliative care for this patient? What are the problems faced by this patient? And what all can be done for this patient and his mother? Thank you.
Thank you, Arjun. And now I'll ask the participants to give in your comments on these questions. So we were talking about mostly about the patient with cancer in the beginning. So this is a 39-year-old man with traumatic quadriparesis. And do you think this patient comes under the so-called spectrum of the patients who are in need of palliative care? So please send in your comments about that. Yes. So I can see comments on yes, we can start palliative. So that's a very good response, because many a times we think that palliative care is for patients with cancer and terminal illness. But as you are rightly responding, palliative care is for anyone with serious health-related suffering. And there are so many patients in our own setting who have had this kind of traumatic incidents in their lives and got treated from a hospital, and then they are sent back home, where they are just lying on their bed, unable to move without support, unable to do their daily activities without support. So there is, I don't think there is a place in a hospital where they can be cared for, and they may not need a routine hospital care also, because their problems are different, their needs are different. So every time taking them to hospital for an acute care setting is kind of very difficult for many practical purposes. Yeah. So can we move on? Yeah, I can. I'm seeing responses about the next questions. He need to give wound care and analgesics and arrange financial assistance. Dr. Arun, so how do you think a wound care can be given for this patient? Because he is at his home, and in the current scenario, like I just wanted to hear from you, like how should we go about giving a good wound care and analgesics for this kind of patients? Would you like to unmute and speak, or would you like to comment on?
Actually, we can by home visits we can go to their home and do wound dressing and give the wound care there.
Yes. Thank you, Dr. Arun. As sir was mentioning in the presentation, when patients are having serious health-related suffering, they should get the care at where they are. Many a times we have seen patients going through a lot of distress just for transporting from home to a hospital. And then they'll be asked to come for review after a week of antibiotics. Then again, for that, just for one review, they have to depend on 10 other families around them, literally to carry him from home to the vehicle and then to the hospital. So that is why many of them are worried about spending a lot of money. I'm not coming back to my normal life, but my family is spending most of the money for my own treatment. Yes, he is dependent on others for his daily activities. Sorry, so there is a comment on the bedsore treatment with regular debridement, hydrogen peroxide, dressing and rehabilitation. Yes, thank you, Dr. Deepak. The dressings that we recommend are slightly different, but yes, the essential part is to provide wound care at home, and ergonomically adjusted job is very important part, because this is not a progressive illness, but they have to live longer with disability. So it's very important to find out the ergonomical modifications at home as well as the job. Yes, so one problem faced by him, Dr. Sublakshmi is mentioning that he is dependent on others for his day-to-day activities. That is, I think, the most common existential distress that we come across, that I am burdening my own family. Especially, this is a 13-year-old young male who is dependent on his mother for his daily activities. So there is a question of dignity. There is a question of total dependence on an elderly mother. At an age where he has to take care of his mother, he is totally dependent on his mother. So these are the existential distress. Why should I be living like this after all? So these are the questions patients usually ask us. What is the meaning of being alive like this? Periodic palliative care visit, yes. So that is one recommendation. So there is a mention about a wheelchair. Yes, to go to church. So there we are again slightly touching upon the spiritual aspect also. Some people go through a lot of distress when they have an incurable illness. or a serious health-related suffering, that is God punishing me? Have I done something really bad in the past? Have I not prayed enough? Why is he punishing me? I didn't have any bad habits in my past life. Or I might have misbehaved to my mother in the past. Now I'm totally dependent on her. So these are the questions they ask us in terms of spiritual distress. Yes, bedsore treatment, periodic visit is very, very important. And along with periodic visit, very importantly, we need to empower the caregiver to take care of the patient regularly at home, because we may not be able to see the patient every day at home. That's the sustainability of the treatment, the continuation of the treatment might be difficult. So it's very important to depend on a lot of community volunteers and to empower the community as well as the family to take care of the patient at home. Analgesics and arrange for waterbed, educate about very, very important point, doctor. It's very important to arrange for proper positioning, skin care, and to arrange for free medications. Financial and spiritual management. Yes, Dr. Sam, teach the family to do the dressing. That's also very crucial. As I mentioned, we can't be there every single day for the patient by giving visits, for giving wound dressing. So it's very important to empower the community as well as the family members. Ripple mattress and vacuum assisted closure. Yes. That is possible, but I think that might need a hospital setting and admission. Many a times that may not be possible for a long-term admission. So if possible, if your setting allows you to admit patients and do this VAC, then that's good. But for a long-term benefit or to give a continuous care, home care would be another option to, home-based wound dressing would be another option. Wound cleaning, teach to the bystander, and they can do it by themselves and prescribe some antibiotics, yes. Yes, Dr. Bilal, community participation is really, really important in this patient, because he needs to be in the society. He would like to interact with other people. So we have a few programs here where we take patients to the outside environment and let them interact with the outside people, so they can just get out of the norm of their own world and to get to interact with other people. Spiritual counseling for negative thoughts, yes. Position change and everything. Yes. So I think everyone understands the importance of the total care part of it. It is not just the pressure sore or, yeah, very important point, Dr. Venkatesh, the mother should be taken care of. So as we have mentioned in the presentation, palliative care does not focus just on the patient, but also it's also about the family, patient as well as family going through this serious health-related suffering. So we can imagine how a 65-year-old mother who's a manual laborer who have to go for work and then take care of the patients for his daily activities. So always the neglected group is the caregivers. When you go for home visit, when you do the consultations, the caregivers are made just to act as spectators, or they are made to stand outside. So they don't get any attention. And we have found in our patient population that caregivers don't take their own medications. They ignore their own health conditions. So that is a very, very important point, to talk to the caregiver. In this case, talk to the mother and ask what she is going through, how she's coping, what kind of support she needs. Is she having any other illness which needs treatment? So Dr. Jennifer is writing, we had a similar case in our rural hospital. We provided regular home-based palliative care by wound dressing and debridement by surgical resident, and small handmade jobs to avert his financial problems. So we focused on every aspect of palliative components and provide counseling to his mother and his community volunteer to support him. So now the bed sores were improved. Dr. Jennifer, would you like to share where you are from?
Yes, ma'am. Good afternoon to everyone. Actually, I'm from Pondicherry. We are doing a palliative care program in a rural and urban health center also, ma'am. I'm a community medicine postgraduate. We had a similar case, but he's around 28 years old. He got quadriplegia from age 15 years. Since then, he is in bed sores only. His mother, who is around 59 to 60 years old, she is taking care of him. His brothers, those are, even though they are earning, they are not looking him. So we took him as our palliative, in our palliative care, and we provided him a regular weekly wound debridement, everything by our surgery resident itself. And we also provided some jobs like making flowers and hair bands. So because he can able to do work through his hands, and physiotherapist also we called, and we gave him some physiotherapy to improve his muscle strength also, ma'am. And he actually he's also so much deprived because of spiritual. Like he used to tell his mother that he want any shawl, starts going to hospital and in care also. So we started to go there, and now his spiritual level and psychosocial level is improved at much level, much higher, because now he started to speak some positive also, like thanks for now I can able to do something so that my mother also happy, and she's trying and supporting me also. And the community members, actually we have to appreciate their work only, because so many members are coming to him and talking positively, so that he have some positive thought also. So we are doing such as support to him, ma'am.
Thank you, Dr. Jennifer, for sharing that. Yeah. So there is a question, there is a comment on mother should stop working as a manual laborer because it's a very heavy work and should arrange for some light works for financial support. That's very true. But many a times it is, many a times we see that very, very commonly that they have to go for some heavy work which they are not supposed to do at their age. So this is one way of rehabilitation. Vocational rehabilitation is one way of supporting the patient as well as family. As Dr. Krishnapriya rightly mentioned, it is about giving meaning to the existence. If he can engage himself in some small activities, making something and contribute a little bit to the family, that makes a lot of meaning for him, his existence, his own existence. And he feels that I'm not just sitting and being a burden to the family, but I'm contributing a little bit to the family. So I think the chat comments almost, I've summarized all the points, but anyone would like to unmute and ask any questions? I'll be happy to take. Any question based on today's session or today's case presentation? We can discuss that.
Ma'am, I just want to ask, are there any specific textbooks or any material that we can refer to also while we are enrolled in this course?
Yes, who's talking? Sorry, I can't see.
I'm Dr. Deepak.
Okay, yeah, Dr. Deepak will be sharing a textbook called Indian Primary and Palliative Care, which will have all the modules covered. We'll share the soft copy, and you can refer that book. If anyone is interested to read more, we can send you Introduction to Palliative Care by Robert Wycross. That is another textbook that you can refer. And after each session, we'll be sending learning materials, relevant articles or reading materials for each session.
Yes, ma'am. I am willing to get more materials.
Sorry, ma'am.
I'm willing to get some more materials so that I can, do some deeper study.
Yes, sure, ma'am. Sure.
And one more realization which I had, like, in rural India, since Kerala is doing a lot with the palliative care, but in Assam, West Bengal, it is very, very inadequate. But only one thing, which is this: people, when we see after some time, the patients suffer from guilt and that we are burdened. This feeling almost cripples them. It is here, I don't know how to, alleviate that pain and how to make the situation better.
Yes, thank you, Dr. Krishnapriya. Yes, we have sessions on dealing with the psychosocial distress, how to assess the distress and how to manage that in a palliative care setting. So we'll discuss that in detail about that in that session. But it will be good if you have a specific patient story that you want to
Yeah,
discuss in the session. Please send it to us.
definitely.
So there is a question about role of insulin in bed sore treatment locally. So Dr. Bilal, there are many, I think, locally developed treatment like insulin, like aloe vera, a lot of topical preparations which is locally made. But we don't have any particular evidence on insulin in bed sores. I have personally seen people using insulin for treatment of bed sores, but there are not much studies or evidence on the insulin treatment. And moreover, with whichever people I've talked, it's slightly like you are using that insulin. Many places it's not that affordable also. So yeah, we don't have any experience in using insulin, but we have seen people using insulin for bed sores.
Is raw papaya paste help?
Yeah, so that is another local treatment available. Many people use that. But again, that is not recommended in any of the guidelines. So we don't have any experience in that. But yeah, there are lot of local treatments available for bed sores. We have a session on pressure sores, but we'll be focusing more on the practicality and the evidence-based practice in managing bed sores. Thank you for that question. So we are about to end today's session. So before we have 4 more minutes. So again, I'm in the beginning there were less number of people. So we have already gone through the ground rules for the session. So kindly send in your case presentations. So by another 2 to 3 days, please send one patient story that you would want to discuss in this platform. That is mandatory, and please keep switch on your videos because the interaction will be much better. And we talk a lot about eye contact and good communication skills that can come only through face-to-face interaction. It's very discouraging to see icons with some alphabets there. So thank you so much for switching on the video. And we'll be sharing the learning materials and the YouTube links. So if you are missing one session, we need 80% attendance. But if you are missing 1 or 2 sessions, you can go through the YouTube link and you can hear the presentations, and kindly send in a 1-page small summarize the points that you have learned from that session. That will be helpful, so that we'll know that you have heard about it and you have gone through it. Anything else, Priya?
No, ma'am. You have covered everything. Only thing is that once you watch the recorded sessions, it will help you to clear the assignments in the first go as well. So it is for benefit of everyone only.
Yeah, we have 5 assignments till the end of the session. It will be sent periodically as and when we finish each module. And we have a lot of queries on the WhatsApp group that my duty time is at 5, I am unable to attend. So if you have the duty time at 5, please better not to join for the course, because the sessions will start on 5 and will finish at 6:30. So if you have some difficulty with the time, I recommend you to choose some other slot for training. Thank you so much everyone for being a part of this program. And we have sent a feedback link in the chat. So kindly send in your feedback.
Yes, feedbacks are very important for us to improve our batches. So please do submit your feedbacks. The link is already provided in the chat box as well as in WhatsApp group. So that brings us to the end of our first session, and hoping that this is going to be a very lively and an interactive and informative learning for everyone out here. This is Sri Priya along with Dr. Sridevi Warrior signing off from the Tips Echo Desk. See you in the next session. Take care everyone. Bye-bye.